Dear audience, let me introduce my PhD thesis investigating the therapeutic approaches of immune-mediated inflammatory skin disease. Let me summarize it. The first project, the JAK inhibitors are very effective in treating immune-mediated inflammatory disease, but the FDA infection warnings have raised the concern about their safety. So there is an unmet need for a comprehensive RCT-based analysis to clarify the reinfection risk. And our findings that the herpes zoster was duplicated compared to the placebo. Influenza risk was also duplicated to placebo, but the serious infection was not significantly higher compared to placebo. Our suggestion that assess the zoster risk before initiating the treatment, vaccinate if appropriate, and monitor for early signs of infections. I am Máté, Krebs, a 6-year medical student and a 4th-year MD PhD student, and my vision is to improve the quality of life of people with immune-mediated inflammatory skin disease by assessing and addressing the risk associated with targeted immune therapies in immune-mediated inflammatory skin disease. I have two specific goals. Both are meta-analysis, and I would like to start with the first one, investigating the infection risk of JAK-STAT inhibitors in immune-mediated inflammatory skin disease. The JAK-STAT signaling is implicated in many inflammatory skin disease. This pathway has become a major therapeutic point for IMiDs, and JAK inhibitors are very effective. And they are increasingly used in the United States. Statistics indicates that approximately 200,000 people are prescribed JAK inhibitors. Despite their effectiveness, the FDA warning specifically highlights the serious infection. As a result, many physicians are concerned about their infection risk. There is an unmet need to reduce this fear around the JAK inhibitors, and it is very important to understand the associated infection risk with JAK inhibitors, especially in patients with atopic dermatitis who have elevated baseline risk. Our clinical question, are JAK-STAT inhibitors associated with increase of infection in immune-mediated inflammatory skin disease? We use Piker framework to structure our analysis. We compared the JAK-STAT inhibitors to placebo or active comparator, and the outcome was the different kind of presence of infection, and our hypothesis, patients with immune-mediated inflammatory skin disease treated with JAK-STAT inhibitors have not significant increased risk for serious infection. And the implication is to balancing the disease control and the infection risk is key to provide a safe and effective treatment. We use this search key. It consists of 3 domains. And at the end of the full text, we have 69 eligible full text. And we are in the phase of grade assessment and in the phase of writing manuscript. I created a summary table where there are lots of kind of infection. In the first column, there is the risk ratio, and I would like to only concentrate on the most important outcomes, which was the herpes zoster. We assessed the risk in patients with atopic dermatitis treated with JAK-STAT inhibitors versus placebo. We used a risk ratio to assess the risk. And these were RCTs. We have 18 RCTs. The herpes zoster is very important outcome because it can cause post-herpetic neuralgia and can cause hospitalization and even blindness if the head is affected by herpes zoster. And the risk ratio was 2, which means that there is 2 times higher risk compared to placebo. But also the prevalence is very important. The prevalence was higher than 1. It was 1.5, which means it is higher than 1. And according to the standard of frequency of drug adverse event, it means it was a common adverse event. So it's clinically also very important. The next one is the influenza. Influenza, we also use risk ratio to address the influenza risk. Influenza is also very important because generally In not the high-risk population, it is a light infection, but in the high-risk population, for example, patients with chronic disease or elderly patient, it can be very serious. So the risk ratio was 2, which also means that it was duplicated compared to placebo, and the prevalence also was higher than 1, so it was a common adverse event. And the last figure that I want to show, it was the serious infection. We also used risk ratio. The prevalence was in the JAK-STAT inhibitors groups below than 1, which means it was a rare adverse event. And the risk ratio was 1.09, which it is not that high, and it was not significant compared to placebo, but it is very important to be aware of the serious infection, but it's significantly not higher compared to placebo. The strengths of our meta-analysis, we only included RCTs. This is the first meta-analysis which included influenza as the outcome, and we are only focused on dermatological disease. Of course, we have a limitation, the low event rates for some infection, the short follow-up duration, and result may not fully reflect a real-world population. Our conclusion, the JAK inhibitors increase a risk of herpes zoster and the influenza, but not the serious infection, and the proper screening, vaccination, and monitoring can support the safe use in dermatology. Implication for practice, assess the herpes zoster risk before initiating the treatment, offer zoster vaccination, and monitor the patient regularly. And implication for research, there is a need for comparing the herpes zoster infection risk across different JAK-STAT inhibitors and compare the doses. And there is a further investigation for investigating the long-term safety. And the second project, investigating the risk of inflammatory bowel disease in patients treated with IL-17 inhibitors. The IL-17 are a strong inducer of inflammatory and contributing tissue destruction in imates. And IL-17 inhibitors are successfully used for treating various images such as psoriasis, hidradenitis suppurativa, and so on. And it was considered as a potential treatment for IBD. But the clinical trials show no efficacy and even worsened the symptoms or caused relapse in IBD. And unfortunately, new IBD cases reported after IL-17 inhibitor therapy. And it is very important to understand this because the patient with hidradenitis suppurativa have an increased baseline risk of IBD, and there is no consensus on whether it is necessary to screen for IBD before initiating the treatment. The clinical question, does the use of IL-17 inhibitors increase the risk of developing or exacerbating inflammatory bowel disease? We use also Piker framework. We would like to compare the IL-17 inhibitors to placebo. And our hypothesis is that patients treated with IL-17 inhibitors have a higher incidence of developing IBD. And the clinical implication is to improving the patient safety and optimizing the treatment strategies. To summarize, I have 2 ongoing projects. I would like to submit the first one in September and the next one in the next year. And I would like to close my presentation with this quote: I never dreamed about success, I worked for it, and thank you for your kind attention.
You are saying maybe it's worth screening an already existing IBD or a pre-version of IBD before the therapy. How would you imagine this? I mean, doing an endoscopy, or how would you screen IBD with no, positive patient history, with no symptoms at all?
There is many options for screening IBD. The standard is the colonoscopy, but it is not cost effective, and it's impossible to do for every patient in the daily practice.
Yes.
But maybe the calcineurin inhibitors, there is a marker. The calprotectin biomarker can be used from stool.
All right, but still it might be high only just having, you know, some infection and not because of IBD.
Yeah, it's not
so
specific.
It's not specific at all, yes.
Yes, it's a very problem.
Okay, and in your meta-analysis, the first one, are you investigating only the adverse events, right?
Yes, yes.
Okay, so I completely got that point. But still, you know, the cost benefit. So still using these inhibitors, maybe it can, you know, solve the already existing disease problems. But of course, the risk for having some other infections that might be higher. And as I could see, the control group was placebo, maybe on each or on every figure, but could you also compare the intervention to other active agent and not only to placebo?
Yes, there was not many options. There was the dupilumab, which is a biologic therapy. We do that analysis, and the TNF-alpha inhibitors. And, but there was not that high difference regarding the infection. But compared to dupilumab, there was a very high difference because the risk ratio was almost 4. That it was very high compared to dupilumab regarding the infection, the herpes zoster, sorry.
Okay.
Only on the herpes zoster, yeah. We could only do that analysis. Yeah.
I'm just curious, you mentioned IBD is associated 5 times higher risk of HS. Is there any reason behind that, or do you happen to know any? Why is that the case?
Thank you for your question. There is not an exact answer. There are many hypotheses because the genetic background is similar, and also the pathological background is similar. For example, there is very important role the TNF pathway and the different interleukins, and also the dysbacteriosis and the bacterium have a very important role in both disease, so it can be the reason for that, but there is not evidence reason for that, as I checked it.
I have a question, and my question would be that does the FDA highlight other risks associated with the JAK-STAT inhibitors? Do you know about it? Yes,
so there was the serious infection which we investigated. There was a thromboembolic events, and also there was the cancer, and they specifically highlighted the cardiac heart failure and also the death.
And do you plan in the future maybe to also investigate these as outcomes, or not really?
Yes, maybe.
You don't know. Okay, thank you.
You said in your first topic that you advise clinicians to assess the herpes zoster risk. What do you mean under that? I mean, everybody is at risk who had varicella. What do you understand?
Maybe as far as I know and as I checked it, if the atopic dermatitis is more severe, it can be a higher risk for herpes zoster, and it can be more serious. So maybe who have severe atopic dermatitis, maybe it's a high-risk population, or the elderly patient who are immunosuppressed due to the age.
Okay, I think all the patients who get JAK inhibitors for their atopic dermatitis already have a severe dermatological condition, because this is why they get the med. I get it with the elderly population, but this is actually not the population where we see severe atopic dermatitis. So I didn't really get this part, but the other ones were really nice. Thank you.
Thank you.